Good afternoon, everybody. Welcome this afternoon to join us to have a bit of an update and an opportunity for some question and answers around the new Locality multidisciplinary team meetings and Locality Frailty clinics. Many of you hopefully do already know us, but I am Louise Ayres. I'm the CBU manager for planned care at CLCH. And I'm joined by Amy, who is our clinical transformation lead for Frailty, also at CLCH. What we're going to do today is talk through some slides, and if the technology gods are kind, hopefully also play you a short video, which will give you a fairly broad overview, a bit of an update on where we are at around the MDT model and Frailty clinics. And then we will open up for some question and answers. You should see, those of you that might not be so familiar with BlueJeans, you should, on your screen down the right hand side, there's a Q&A button. Any questions that you think of during the course of the presentation, please do feel free to type them in there. We probably won't stop to answer the questions as we go, but we will save them up and then have a look at the end at what's come in throughout the presentation and hopefully resolve as many of them as we can today. So without further ado, I can see we've got a good number of attendees actually sitting with us, and I can see your names. I can see we've got good representation across quite a range of teams and services and organisations, which I think is really positive. So we'll make a start. Amy's going to take us through the first section, which is about our Locality MDTs, and then I'll do a short section on Frailty clinics. We will make a start and see where we get to. Katie, could you get to the first slide, please? Over to you, Amy.
Thank you, Louise. So CLCH provide a host of services, community services across West Hertfordshire, and complex case management and the Community Frailty and Falls Clinic are two of the pathways in which we want to provide an update to you on today. So within the complex case management pathway, this is where the Locality MDTs sit, and we'll go on to talk a little bit more about those more specifically. You'll see the image on the bottom of the slide here. So we've got a single referral form, which is for both pathways, and that's available on the DXS system and also as a paper copy. So many of you will already have it in your services, and we'll make sure it's circulated more widely following this. The paper copy is then, on completion, is emailed to the relevant locality box, and that all comes to the CLCH single point of access, at which point the referrals are registered. Just want to highlight, if you do have a case that you do want to refer through to this pathway, it's really important that we have consent from the patient or the person that you're working with, in that they agree to the referrals to be completed. We recognise in some complex cases, actually, people might not have the capacity to consent to a referral, in which case we'd need evidence for a best interest decision as to why it's important that we do proceed with the discussion potentially around that particular case. If we move on to the next slide. So what we want to do is just give you a bit of an overview of what happens once the referrals come in. So as I said, the referrals are either received by DXS or emailed through, and we will accept referrals from a whole sort of host of our partners across health and social care system, including the voluntary organisations as well. And when referrals are received, we will triage them within 1 week to confirm their suitability for this pathway. The referrals that potentially aren't suitable are those where actually if there's a single need or the issue or that has been identified could be addressed by one single professional group. So, for example, if a patient needed a carers assessment, then that wouldn't necessarily be appropriate to come through complex case management, but you could complete an onward referral to adult care services for that to be addressed. Or likewise, if a patient needed a therapy assessment, for example, that would go through the usual routes to the community therapy team. So within each locality, we have a dedicated complex case manager. These are Band 7 nurses who are responsible for triaging the referrals that come through and then overseeing the care of the patients, people coming through to that service. And what we envisage is we'll end up with 2 cohorts So there will potentially be the referrals where actually there's been quite a lot of professional involvement already, and it's quite clear that an MDT is needed potentially within 2 weeks, straight away to address and bring everyone together. So we're addressing the interventions to date and determining a single plan of care going forwards. But alternatively, it may be that actually our complex case managers could work with the person who's being referred through up to a 12-week period to do a bit more investigatory work around what's happening already, what the care needs are, and potentially liaising with sort of individual professionals to address those needs without the case having to go to an MDT meeting. If, however, it's identified at a later point that an MDT meeting would be beneficial, the two cohorts sort of do overlap in terms of the MDTs and the complex case management pathway. We move on. So some further details regarding the locality MDTs. So as with the complex case management pathway, this is a service for adults, so over 18s registered with the Herts Valley GP. The MDTs provide a virtual forum at present. Previously they would have been attended in person, but due to COVID, we are conducting all MDT meetings virtually at present. We've got a forum for complex case discussion. This work builds upon the success of the historic MST model that we've had, and it's an inclusive approach. So regardless of the person's age, obviously over 18, their diagnosis, so we are talking about people potentially registered with the adult disability services, for example, as well as those who access older people's services, and when we're thinking more about our frail population. And regardless of their home setting as well, so we are running two services in parallel at the moment, so supporting people at home, but also supporting people who are residing in care homes. So regardless of where the person lives, there's the opportunity for an MDT discussion as part of the locality MDTs. The meetings have a wide range of input from health and social care professionals, and this is supported by the funding in the locality delivery plans. And the ultimate aim is to achieve a single coordinated plan of care across organisations. Okay, so next we're going to talk about when the MDTs take place. If we move on, Daisy, thank you. So there's one MDT session of approximately 3 hours, which is available per locality per week. So the schedule is as you can see on the screen there. So Tuesday afternoons are our Decorum MDTs, Wednesday mornings St Albans and Harpenden, Hartsmere's take place on Wednesday, and Watford's take place on a Thursday morning. Do you move on? So we have commitment from across the organisation to have a core membership of the MDT meetings, and there is some slight variation within that core membership depending on the age of the person or potentially where they live. So we have our complex case managers who are employed by CLCH, or the care home support practitioners, so the equivalent but supporting residents in care homes. We have consultant geriatricians now supporting all of the MDT meetings, either employed and working on behalf of us from West Herts Hospital Trust, or the Royal Free, so Barnet, supporting Hartsmere locality. We will be inviting the patient's own GP to the discussion of their patient, and the aspiration going forwards, once the primary care networks are established, is to also have GP representation who would be there for the whole meeting, in addition to the patient's own GP attending for individual discussions. We have representatives from social care, so across the different services, so whether it's older people's adult disability service or the 0 to 25 service. Same from HPFT, so adults and older people's, and our community navigators, high intensity user navigators, or link workers with the GP surgery. So as I said, depending on the case being discussed, some of that membership might change slightly, but we'll have representation from those core groups. And there'll be a chair, an MDT chair per locality and per discussion. In addition to the core members, depending on the need of the person being discussed, we'll also the list on the right-hand side there. It's not an exhaustive list by any means, but it's just to give you an idea of some of the groups and other professionals that we've had attending MDT discussions to date. Okay. I'd like to give you an example of a recent case that has come through complex case management pathway and one of our locality MDT meetings. So the slides have come off, but while Stacey's fixing that, I'll start to explain the case to you. So we had a referral which was received from the Community Navigation Service during the COVID-19 pandemic peak, particularly with concerns regarding the client's presentation. So we had a lady who was doubly incontinent, appeared to be lacking motivation, depressed, sleeping on the sofa, and it was known that she had financial difficulties. And all of these areas seemed to be exacerbated due to the pandemic and appeared to be social in nature. In terms of her past medical history, she had been experiencing falls, she had alcohol dependency, and we knew that she had a traumatic subdural hematoma. When the complex case manager started investigating a little bit more about this person's background, we realised actually there's very little information around the subdural hematoma and potentially what the lasting effects were. And this became the key focus of the investigation. With the geriatrician's support, we were able to access the discharge letters through the hospital to establish at what sort of time frame the injury had happened. And through that, we were able to access further records and particularly the brain scans that were completed at the time in the reports, which confirmed that due to the nature of the injury, actually, this lady would have high-level functioning or deficits in high-level functioning, apologies, including memory and executive functioning. And actually, she'd had non-attendance to appointments and didn't always answer the phone, so she'd never actually received any neurological follow-up. So the decision was made to schedule an MDT meeting, which was attended by the adult disability social worker, community navigator, OT and home care provider, including then the consultant geriatrician and the complex case manager. Being able to sort of review all the evidence and investigations that had been completed, we were able to come up with actions around increasing her care package. The financial difficulties were actually because she couldn't remember her PIN, so the care agency were going to support her to the bank to access her money. And there were numerous interventions around the safety of her property at home, and it was felt that a referral to the mental health team would also be appropriate. So to summarise, prior to coming through to complex case management, the needs, the service users' needs were just not being managed at all. But actually, through the comprehensive assessment of the service users' needs, and by being able to kind of piece all the information together, actually, and sharing that information, we're able to result in a care plan that was appropriate to her needs, which is making quite a significant impact. So we're going to swap now to the video, and as Louise said, hopefully the technology gods work with us. So this is just to give you an idea of potentially how the localities can support you, with some feedback of those who have used the service.
The median age of death for people with learning disabilities is 60 years, and for people who have a profound learning disabilities, this could be as low as 40 years. It's really important that assessments are done in a collaborative and holistic way that involves the person's carers, their relatives, and any involved health professionals, and also that all of this consideration is brought into best interest decisions when that's being made for the patient.
It has been a difficult few months for everyone, but one of the consistencies throughout the COVID response was the recognition of the importance to have access to MDT forums. These have been developing over time from the old-style MST meetings into the newly launched Locality MDTs, with the addition of the consultant geriatricians. This new format has enhanced the meetings, creating an opportunity for a well-rounded, holistic, person-centred approach. It can be easy to work in silo, especially at times of pressure, which can result in poor outcomes. The MDTs, however, ensure relationships remain strong and all services, statutory and voluntary, are able to contribute and collaborate, resulting in a wide breadth of knowledge and access to expert advice. The objective is to work as a united, integrated front to achieve the best outcomes for people, focusing on what can you do rather than a focus on what we do not do.
Sorry, I was on mute. While we just get the slides back up onto the screen, I will just take the opportunity to thank everyone who contributed towards that video. Some of you might recognise your statements or your voices covered there, and absolutely this is a service that can't be done by any one organisation. It's a joint thing, so it was great to get input from others to help develop that short video. And just in the nick of time, these slideshows come back on. Can I have the next slide, please, Daisy? The next one, the one with the Frailty Clinic bit on it, thank you. So I'm going to take us through the next few slides, which just outline the introduction of the Frailty Clinics. So many of you will be aware that we had an intention to launch some locality Frailty Clinics right at the beginning of this year. And we were just right on the cusp of launching them as the COVID situation emerged, and so the decision was made to delay them. But I'm really pleased now to be able to say that we are getting them up and running in all 4 localities over the next few weeks. So the Frailty Clinic is sort of an additional offer to any patient who's on this MDT and complex case management pathway. The idea being that for some patients, we can't resolve things by talking about them in a meeting. They do need to have a comprehensive clinical assessment undertaken to try and understand really how to best optimise their health needs. On the next slide, please, Daisy. We've got some criteria. So the Falls and Frailty Clinic is specifically set up for people who have moderate frailty, so a Rockwood of at least 6. That are scoring at least 3 on the Falls risk assessment tool and are at risk of a preventable hospital admission. I feel it necessary just to clarify, when we talk about preventable hospital admission within this service, we're talking about longer term hospital admission. We're not talking about imminent going to hospital today, tomorrow or the next day. The service, unfortunately, isn't one that's set up to respond to people who are in that kind of crisis situation and needing urgent support. I will use this opportunity very quickly just to remind everybody that other services are available for those people who are needing urgent support through either the CLCH Rapid Response Service or through the acute trusts and frailty units there. So those are the 3 key criteria for frailty clinics, and there is just sort of a 4th one that spans right across, and that's clinical judgment. So that's where recognising that patients don't necessarily fit neatly into boxes. There may be people that don't necessarily meet those criteria, but there is a real sense that a frailty, a comprehensive geriatric assessment in frailty clinic would be useful. Thanks, Daisy. So we've had to do some thinking about the Frailty Clinic model, and when we originally talked about launching it, we had an idea of really a one-stop shop for a patient, that they can come into a clinic and see a range of professionals and have a range of assessments undertaken from nursing, physio, OT and the geriatrician. In the context of COVID, we've come to the realisation that that doesn't feel appropriate to bring frail people who will generally be quite vulnerable to COVID into a clinic situation where they're having contact with multiple professionals. So we've reviewed the model, and the approach that we will now be going for, having received the referral through whatever route, we will first of all undertake a home-based assessment by a therapist or a nurse, and that assessment will include the collateral history, an assessment of that person's home environment and function, some baseline observations, particularly lying and standing blood pressure, and an opportunity really to liaise with family members and to make sure that we've got a really full picture of all of the things going on in that particular patient's world at that time. And that will then be followed up by a clinic-based assessment by the consultant geriatrician. And the idea is that by having done that home-based assessment first, we can then make that consultant geriatrician contact really streamlined, really focused, and of a minimal duration to limit the amount of time that each of these frail people is spending in a clinic setting. Following that assessment with the consultant, there will then be some debrief and decision making, so a short virtual MDT discussion between the geriatrician, whichever clinician has done that home-based assessment, and other key people that might be involved, so people like the complex case manager that Amy has already described. We think in the context of COVID, we think this is a really good offer for patients to do this additional level of assessment and problem solving. Yeah. So, as I say, we're kicking these clinics off over the next few weeks. Hertsmere is our first locality to go live, which will be next week, and then followed in sequence at sort of fortnightly intervals by Watford, and then St Albans, and then last of all Dacorum at the beginning of November. Each of those clinics has got a base within the locality that they serve, so we're hoping for patients that transport and access will be really streamlined. So to summarise the whole kind of service and pathways right across complex case management, MDT, falls and frailty, is that it is a comprehensive approach to multidisciplinary assessment and working to support our most complex patients in each locality. Just in terms of managing expectations, it's not a service that will offer long-term support to people over an extended period. The idea is that we assess them, make decisions, make plans, and get those plans implemented by the most appropriate service, rather than the patient remaining under the umbrella of the service on an ongoing basis. As Amy has said, it's not a service for people who have the sort of clinical need that can be met by one single service. Unless that service is already involved and experiencing difficulties. And as I said, it's not an urgent rapid access service for people at imminent risk of hospital admission. So that, I think, wraps up the information that Amy and I had planned to share, and opens us up to some question and answers. So I've got some support in the room just monitoring that question and answer in book. We're just going to check whether there's anything in there at the moment. We have received no questions. Now, I'm sure out there must be some questions. So I think we'll just sit quietly for a moment and two and see if things come in. Please don't be shy. Don't be shy. You know, we want to kind of hear where you're at with this, if there are things that it would be helpful to clarify.
Just while people are thinking, Louise, it might be worth us mentioning that we are recording this webinar, so we will be able to upload it and share it widely following this. So colleagues who haven't been able to attend, and I did receive some emails from people saying apologies they couldn't attend, but can we share it after? So we are recording it, and we do hope to share it through the same sort of stream that we sent the invitation to.
Okay, we have got a couple of questions come in. One is about emailing the PowerPoint over. Really happy to do that. I think we've got obviously the offer of the video of the webinar, but if people prefer reading material rather than kind of audio-visual stuff to engage with, we're happy to share share that. There's another question here which is about the complex cases supported by the complex case manager, and in particular whether the professional who made the referral will be involved with it. So the complex case managers are people who, those of you that have been working in the area for a while, will have been used to previously calling community matrons. So the idea is that any patient coming through that complex case management route will have an assessment with that complex case manager and will be supported to develop over the course of that 12-week period a sort of long-term conditions management plan which will help to optimise and stabilise their condition. Absolutely, the expectation is that where the referrer is continuing to be involved in that patient and where the care plans need to be coordinated, we want them to be part of that process. So the answer about will the social worker, for example, be involved? Absolutely. Further, oh gosh, I think I might have skipped some. Further questions.
There's a note here about the CGA, so apologies, that's the Comprehensive Geriatric Assessment. So that's what the acronym CGA stands for. So it's a standardised assessment which is holistic, covers many domains. So between the therapist, nurse, consultant geriatrician, the CGA in its entirety will be completed to help determine a plan going forwards.
There is a question here about how do we refer. So there is a Word document referral form that's been developed. Anyone working in primary care, there will be a DXS through the GP DXS referral system. Anyone that's not on that system, we can provide you with a copy of that form to use, and it's just then sent in by email, and the email addresses are at the top of the form. We have already circulated that form, I thought, fairly widely, but the fact that someone's asking the question suggests that it hasn't quite got everywhere that it needs to get. So we'll make sure that we send that back round again after today. We've got a question here about timing and the GP slots. That very much is our hope. So the question recognises that GP appointment slots typically are booked at 10-minute intervals, and whether we can be, I suppose, slick and organised enough about our MDT function to book a slot in with a GP that gets the best out of their time, but also doesn't keep them kind of on hold and delayed. Certainly that's the aspiration. We have had a few examples where GPs have really successfully been able to dial in using the video conferencing functions from within their clinic rooms and have a really useful contribution to the MDT conversation. We recognise that diary management is a real challenge, and I think it's fair to say we're kind of learning as we go in terms of how to really make the best of that GP input and make it as sort of streamlined and painless as possible for everyone concerned.
The question about definition of high intensity users. So Paul has asked about the MDTs. We are recognising that they are for those service users who are high intensity users, and what we mean by that. So we've had some discussions because there is reference to 3 admissions within 3 months versus perhaps 3 attendances in 1 month. And I understand from discussions that I've had with Paul and other colleagues that I think there's a bit of a wider piece of work going on at the moment to determine exactly the criteria that we should be working towards. So the referral should come through, and as part of that triage, the complex case managers will be looking at a number of attendances, to whether that's A&E or actually the demands on other organisations. So we have got the 2, so 3 and 3 months at the minute, but recognising actually there is that wider piece of work. I don't know if you want to add anything to that, Louise.
Yeah, I think there is the official definition of a high intensity user. As you say, there's 3 attendances in a set period. But that's very much about people who are high intensity users of unplanned facilities in A&E or in acute hospitals. My interpretation of high intensity users as part of this is broader than that. It's people who use a lot of services across a lot of a lot of providers are not just based on kind of GP or A&E attendances. So yeah, we're happy to be a bit more open, I suppose, in terms of that diagnosis. People who are receiving a lot of services generally. We've got then a question about when a referral is not accepted, how is that communicated back to the referrer? So yeah, absolutely, the referrer will receive an outcome letter if in fact it is determined that the patient's not appropriate for the service for whatever reason. I would really hope that the complex case managers through the triage process would be able to sort of actively navigate for that patient. So I think one of the examples that we've previously given is where a patient who's had recurrent falls maybe hasn't yet had a therapy assessment. I wouldn't expect for the referral to be rejected and a request made to the referrer to then make a community therapy referral. I would expect the complex case manager to be able to arrange that themselves, so that the letter that comes back out to the referrer doesn't say not for this service, it says I think it's for this other service and I've arranged for that to be done, if that makes sense. Coming in thick and fast now. I should never have encouraged you on the questions, everybody.
There's a question here about advanced nurse practitioners who support care home assessments, who provide a lot of support to care homes, perhaps in place of GPs or alongside GPs, and whether they could provide the input to the MDTs. Absolutely, we have this happening already. So it would be the most appropriate person who knows, or appropriate professional who knows the person being discussed, and whether that's a different role within the GP surgery as opposed to just the GPs, that we would welcome who was most appropriate.
The question about just wanting to clarify the learning disability element, because the video was very focused on learning disabilities. Am I muted still? Am I muted? Sorry. I don't think I'm muted on my screen. Amy's shaking her head. I'm not muted. I apologise, everybody. That information over here. So the video was quite focused on learning disabilities, and I suppose that's about us making the point that people with learning disabilities are included in terms of ability to access the service. But absolutely, it's not specifically for learning disabilities for all patients with complexity or frailty that would require this MDT approach.
Question about how easy it is to refer and whether that's possible through System 1. So the referral form is embedded within communications and letters for those of colleagues from CLCH who are on the webinar today. So if it's not within your particular service, then we'll put our contact details up at the end of once we finish the Q&A session. So do email and let me know, and we can make sure that it is within every unit if it's not, but I'm aware that it is already embedded within System 1, so it would auto-populate as much of that information, and the same goes for other organisations. As Louise said, we have disseminated it widely, but if it's not visible or can be more visible on your systems, then let us know and we can make sure that you've got copies of the form to make that happen.
Another question about face-to-face versus virtual, and feeling that virtual works quite well and avoids travel, parking and what have you. When, again, I suppose learning from the COVID environment that we're all working in, when we were originally planning this, we wanted it to be a face-to-face meeting. We felt that was really important from a kind of relationships and communication perspective, that particularly the core members of the MDT are able to kind of see each other in the flesh, as it were. I think during the course of COVID, we've all become much more used to the idea of using video conferencing and virtual solutions instead. And so we can kind of keep that under review, really, and at the point at which post-COVID, whenever that is, we're in a position to start something face-to-face, we can take a bit of a view on whether, in fact, we feel that virtual does work well and we want to continue that, or whether people have got an appetite to returning to something more physical in terms of that meeting space. I'm hedging my bets on the answer to that question, I'm afraid.
I've just had a scroll through the questions, Louise, just to see if we've missed any. As you say, they suddenly came in thick and fast. So there's a question about Frailty clinics. They're about to go live, and will there be more information, including how to refer clients? So as we've explained during this webinar and on the slides, there is a single referral form for both complex case management, which includes the MDTs and also the community Frailty and Falls clinic. In terms of communication wider beyond that, so for GP surgeries, there will be communication coming through the CCG, more around the Frailty clinics, and we hope that this sort of webinar gives you a bit of an idea of what we will be working towards. It is a revised model, so there will be some learning to come as we go through, and it will be good at some point to provide an update as to some sort of cases that we've had potentially come through that forum, Louise, so that to give you a better idea of which client groups potentially have particularly benefited from that. So if you're working with a person where you think you would benefit from support, either from complex case management or that actually there are concerns which haven't been or can't be addressed through the professionals involved, then do send the referrals through. Say they're triaged. There is some investigatory work that will go on to establish the current sort of clinical presentation, as well as their social needs, etc., and we'll determine whether they're potentially suitable candidates for clinic.
I've had a couple of new questions come through just whilst Amy was providing that one. So there's a question here around whether the service is replacing the holistic care service in Dacorum. So apologies to those of you to whom this doesn't relate. In our Dacorum locality, we do have a provider called Dacorum Healthcare Partners Limited. They are providing some services on behalf of CLCH in the Dacorum locality, and the MDT service is one of the things that they are providing. So it's not replacing the holistic care team as you've called them here. It is a service provided by that team on behalf of CLCH. Hope that helps. We've got a question about whether there are full services available in all localities to refer patients to from the Frailty pathway. There are, so there are a couple of options for people who are experiencing falls. We've got our home-based community physio and OT service that sits within the main CLCH contract as part of our planned care service. There is also the falls and postural stability service provided by Connect Healthcare, which is a very specific falls piece of commissioning. So yeah, we do have those falls services. There's a request here from someone around a meeting or webinar around the wider range of services from CLCH. I will absolutely take that back as a suggestion. Hopefully you have got access to the CLCH Pathways booklet that was put together as part of the launch of the new portfolio of services that does provide a lot of that information. I have made a mental note of the person who's asked that question, and I will email you a link over for that. So that you've got that available in the short term, but absolutely I'll take the suggestion back more widely that you would find that useful. There's a question here, can patients attend an MDT? Yes, absolutely, if that's something that they wish to do or are able to do. Likewise, their family members, relatives, carers can attend. We've certainly had a good deal of success in the past with including those people. And again, with the virtual technologies that we've got, that perhaps makes life even easier, even for remote family members. Can we start referring before the service is up and running, so you've got material to get started with? Yes, please. Go ahead and do that. So for the Frailty clinics that aren't quite live yet, the referral form is live on the system. DXS, and we're happy to start receiving referrals. I suppose that comes with a slight health warning that there is a limited capacity in that clinic. It is only one clinic a week per locality, which inevitably has limited capacity anyway, but also with the current COVID restrictions, with additional cleaning requirements and things between patients, we are going to be working at a slightly reduced capacity in the clinic. So very happy to receive referrals, but try and be selective so that we can work it through. There's a question. Can you also email it to me? Is that the Pathways booklet? The link for the Pathways information. I'm assuming that's what you're referring to there. Please pop that message in if that's not what you mean. And then a question from a colleague at West Herts about viewing the MDT plans made at clinic. Amy, have you got any thoughts or suggestions about that?
Yeah, so for both MDT meetings under the complex case management and also the outcomes of the clinics, there will be an outcome letter for both, which will be sent to the GP surgery. The patient will have a copy and it will sit within System 1. For the MDT meetings, as part of the locality MDTs, if there are other professionals actively involved, they will also receive a copy of the letter who've contributed to the discussion. It's quite difficult, I guess, sharing information in a forward way, potentially with the acute trust, and it's about safety, being able to store information as well. So I would say that if somebody has presented in hospital and you're aware that they have attended the Frailty clinic, if they've been able to tell you that, then do get in touch with through the single point of access with CLCH. Or likewise the GP surgery. That information will be held there, so that we can share with you the relevant information. That's a question about
the Pathways booklet. Just acknowledging that I've seen that, and I'll make sure the link gets sent to you. And also a question about whether we can circulate the Q&A afterwards. So we'll absolutely make a note of the questions and send some sort of FAQ type document out to the group.
We can embed the link to the Pathways document perhaps in the frequently asked questions, Louise, so that it's available then to everyone. That's good. We've had a good number of questions come through, 26. But I think I saw one we potentially haven't answered, which was around the complex case management pathway and what support does that look like. So predominantly that will be the complex case manager supporting the person with the support. So we also have complex case care coordinators working alongside the complex case managers. So between the two people within each locality, they would of course draw on the support of other professionals where that's appropriate. So it might be a joint visit with a social worker, for example, to understand what's going on. It may be that they're looking at some of the components of, as we've said, of the comprehensive geriatric assessment, whether there needs to be a medication review, for example. So as Louise also referenced earlier on, it's an involvement of the community matron role. So it will look slightly different, the level of input per case coming through, because it will be dependent on the needs of the person. But it is up to 12 weeks, and as I say, working alongside other professionals who are involved or seeking support where needed to manage those cases.
There's been a really practical question asked by a colleague in community navigation, that when you receive the MDT meeting invites, do you find it difficult from the NHS number to identify which person that is, and that the name would be helpful? I'm sure we can sort that out. That seems like a quick fix. Thanks for flagging that.
Yeah, that was brought to my attention yesterday, Carol, so apologies that we weren't fully aware that was the case before. So just from the information governance point of view, we were opting to share NHS numbers, but recognising now that actually not every service is built in the same way to find people on your electronic systems. That looks as though the questions have
slowed
stopped
down.
coming in now.
Just to acknowledge, there's an email address just been provided by someone. I've seen that. Thank you. Okay, it looks like questions are slowing down. We'll just give a minute to see if there's any last minute kind of thoughts and queries. So there's a question just popped in about how the referrals sort of interlink between the MDT pathway and the complex case managers. And
we appear to have lost Louise.
we'll
Oh, you're back. Louise, we lost you then from when you started to answer that question. Maybe having some technical difficulties over in Harpenden.
Have I made it back, folks?
You have made it back now. And so you cut out just as you started answering about the link between complex case managers and MDTs.
Okay. Apologies, everybody. The technology gremlins were going to get us at some point. So yeah, the two pathways sit closely side by side, and there's no need to make referrals to both. Just refer the patient in once, and we, based on our kind of triage and assessment of the patient, will navigate them from MDT to complex case management and back again, however that seems to flow right for the patient. And another request for the pathways booklet. As Amy says, we'll pop a link to the pathway booklet in the feedback that we send out after this session, so that you all get access to that. Any other questions? Nothing. The question coming in screen seems to have slowed down. Okay. I think on that basis we'll draw to a close. Amy and I would like to thank you very much for your time and engagement, and really healthy questions and things at the session today. We will sort of get things packaged up and shared with you so that you have the information we've presented available for your own review, and also for sharing with any other colleagues that perhaps were unable to be here today. Could you pop
the last slide.
So hopefully magically appearing on your screens now is the final slide of our presentation, which has Amy and I's contact details on. Many of you will already have them and have one of us on speed dial potentially, but do make a note of them. And if you have any other thoughts or comments that come to you and you want to come back to us, please do get in touch. If you have any more general kind of thoughts and feedbacks about how today's session has gone and whether it was useful, please also get in touch and let us know. It'd be great to get some feedback. Obviously we're not quite used to doing things this way, so it would be helpful to understand from your perspective how it's gone. I think apart from that, we will say thank you and goodbye for now.
Thank you.